This is Mark Newman, the president and founder of Precision Analytical, and this video is intended to assist you as you interpret your results from a Dutch Complete. So we're going to go through each page of the report and give you some information that'll help you to understand the report. We start the report off with a summary page, so we can see on the top part of the results, we can see the total for the estrogens, progesterone, and testosterone. Now, those markers, those hormones are going to have more information for you on page 2 and 3 as to the metabolites and a further breakdown of those. So we'll get to that. But on the summary page, we're just looking at a snapshot of everything as it relates to female hormones, so estrogen and progesterone. You can see the key over here to the side, which is helpful in knowing that the little purple band at the bottom, the entirety of that range is the postmenopausal range. So, for example, for estrogen, total estrogen, 4 to 15 is normal. If you're postmenopausal, it'd be pretty low if you were premenopausal. Then up higher, you can see the premenopausal range is between these two stars. Then the results are plotted similar to a speedometer. So you can see for this particular patient, the total estrogen is high normal, almost out of range for a premenopausal woman, so she's got a lot of estrogen. And then when you look at progesterone, you can see that it's actually right in between, a little higher than a postmenopausal woman, but lower than a premenopausal woman. So the results are presented so that the graphical representation should tell you most of the information that you need to know about this particular patient. As we go on further down, you can see the total of DHEA production. You can see then the cortisol pattern. So this is the free cortisol pattern throughout the day. And we'll get into that in more detail when we get to the adrenal hormones on pages 4 and 5. You can see the total of free cortisol here, and then the total of the cortisol metabolites, what we call metabolized cortisol. And that's the entirety of the results there on the first page. Below that, you can see some comments that may be specific to your case. You'll want to read those comments there on the first page. And then there are also some additional video links at the bottom, this video being one of them. As we move on to page 2, you can see this is kind of your classic lab result. So you have the name of a hormone. So if we're talking about estradiol, you can see the name of the hormone here. You can see the result, in this case, 5.1. You can see the premenopausal range and the postmenopausal range. If you are pre or postmenopausal, this will present the same way. We want you to be able to see both of those ranges. And then you can see the description here is relative to the luteal or the premenopausal range. So if you're postmenopausal, you'll want to also look very carefully at that postmenopausal range to see if your results are normal for your age and demographics. At the bottom of the page, you can see a couple extra ranges. So the follicular phase is the early part of a cycle. So for a premenopausal woman, your estrogen levels, for example, are a little bit lower in that follicular phase. So that's days 1 through about 7 of your menstrual cycle. You're going to have lower levels of estrogen. And then when you hit ovulation, you can see that those levels get their highest there. So that's a lot of estrogen at ovulation. And then you can also see the same thing for progesterone, the follicular phase, and then at ovulation, it's actually the same for progesterone. And then you can see a separate range for when a patient is taking oral progesterone. So if you collected your samples at the wrong time, at a different time, we ask that you collect your samples generally between days 19 and 22 of a 28-day cycle. If you collect it instead on day 5, you can still get some information by having the appropriate range for those hormones. This is a graphical representation of the reproductive hormones, so progesterone, estrogen, androgens, and all their metabolites. So we can see that on the upper left-hand corner, you can see the androgens. If I look at a little better cleaned up picture of this, you can see that we've got the androgens in the upper left, you've got progesterone in the upper right, and then you've got all the estrogen metabolites here on the lower right side of the report. Now, if we want to focus in on the estrogens, what are we going to look at here? We've got a whole bunch of estrogen metabolites that we can see. E1 and E2 are considered sort of parent estrogens. Estradiol is the estrogen that your ovaries are actually making, and then it gets converted to all of these metabolites. So you'll want to look at those very carefully. We saw on page 1 the total of the estrogens. So first thing we're looking at here is just the overall production of estrogen. Where are you relative to what's normal for a pre or a postmenopausal woman as it relates to estrogen production? Then we can move on from there and look at metabolism. Now, metabolism of estrogen has two different parts. We've got phase 1 and phase 2. So these three colored arrows here represent phase 1. So basically 3 doors the estrogen can go through in its metabolism in your body's efforts to get rid of it and process it. You've got 16-hydroxylation, 4-hydroxylation, and 2-hydroxylation. So hydroxylation meaning adding an OH to the group. So there's 16-OHE1, 4-OHE1, and 2-OHE1. And we want to look at the relative distribution of those estrogens. We'll look at that more closely in a minute, but then we also want to look at methylation. Methylation is the process of taking a hydroxyestrogen like 2-hydroxy or 2-OH and converting it to 2-methoxy, the methylation process. And what we typically see is that this methylated product here is about half of the 2-OH. Meaning if you've got a 4.8 like you see here, what would be average would be to get around 2.4 for the 2-methoxy, and that would put you right in the middle of this methylation index, meaning you're average, higher than half the population, lower than half the population in your ability to methylate those estrogens. In this particular case, she's quite a bit lower than that at 0.8, so that's why her methylation index is low. So she's not methylating super well. That's phase 2 or methylation. On the upper left here, I've moved this for you. It's typically on the upper right. You can see progesterone. So progesterone is unique in that it's not in urine, not as progesterone. It has to get turned into these metabolites first. So we have alpha pregnanediol and beta pregnanediol. These represent the 2 main pathways that progesterone goes down. And when we correlate those numbers to serum progesterone or blood progesterone levels, we get a really nice correlation. So what we're doing is we're measuring these two, and you can see they're a little higher than a postmenopausal woman, but a little bit lower than a premenopausal woman. The value then up here represents a weighted average of those two. So it's halfway in between those two. And then if you look back on page 1, what you'll see is progesterone listed as a serum equivalent. There we've taken all of the correlation data that we've accumulated, which is quite impressive, and we've been able to predict what a serum progesterone may be in this particular case. So you can look at that value and you can look at these 2 metabolites to get an idea of how much progesterone is the patient making. Now, when we look at phase 1 metabolism, we want to look at a couple of things. We want to look at the ratio of these hormones. So what you can see here in the pie chart is the expected percentages are about 60 to 80% down that 2-hydroxy pathway, around 10% or 7.5 to 11% down the 4-hydroxy pathway, and then 13 to 30% down the 16-OH pathway. Okay, so what we want to say is, okay, well, what about this woman? Is she average? Which pathway is she preferring? So you can see here that the 2-hydroxy pathway is less than 50%, meaning this pathway is not as well represented as it is in most women. The 4-hydroxy is within that range, and the 16-hydroxy is far above range. So we can see that this pathway, this 16-hydroxylation, is much higher than the 2-hydroxylation. And there are some consequences of that potentially. 16-hydroxy-E1 is a much stronger estrogen than these other metabolites. So that's something that can be relevant. And if you need more information on that, There are other videos that speak to specific issues with estrogen metabolism, but what we're first trying to establish here is just which way this patient prefers to push their estrogen. Generally, 2-hydroxyestrogens are considered the safer of the estrogen metabolites, and so we're wanting to evaluate that. The other thing that we can evaluate here in looking at the phase 1 metabolites of estrogens is just very generally whether the estrogens are pushing down these phase 1 pathways. So if you look at this woman, she's a pretty good example of having elevated levels of these parent estrogens, but then if you look at 2-hydroxy-E1, it's low, right? So that woman's not pushing her estrogens down this phase 1 pathway very efficiently. So that's what we can evaluate. How much estrogen are you making? How does your phase 1 metabolism look? And then how does that methylation process look for this particular patient? Now, when we look at the androgens, these are the male-related hormones. So testosterone is, of course, better known in men, but female patients have testosterone as well. So we can see here that DHEA makes DHEAS and then comes down this way and makes these two metabolites, etiocalanolone and androsterone. On page 1, what you'll see is those three markers, DHEAS, etiocalanolone, androsterone, added up to make total DHEA production. So if you add those three up, they're the largest metabolites of DHEA, and their sum, or their total, gives you a good idea of how much DHEA is being made for the day. Some of that's also going to get turned into testosterone. So we want to look at DHEA production, and we want to look at testosterone production. Now, those hormones are going to change a little bit with age. So this is an overall age range. So you can see, for example, DHEAS goes from 20 to 750, which represents the low part of the 60 and over range and the high part of the 20 to 39 range. So what we want to look at there in a particular patient is which age range does she belong in, and then what's normal for her age. You want to look at what's normal overall, but what's also normal for a patient's particular age group. So we're looking at DHEA levels, we're looking at testosterone levels, and then we're also looking at metabolism patterns. This is one of the advantages of urine testing. We know that when androgens go down this 5-alpha pathway here, they become more androgenic. Most famously, when testosterone goes down this 5-alpha pathway, it becomes dihydrotestosterone, or DHT, and that's 3 times as potent as testosterone. So in a patient like this, you can see there's a 5-alpha preference. So this pushes towards alpha, and you can see why. Androsterone is elevated, and the 5-beta metabolite, that's a non-androgenic pathway, is not elevated. So there's a preference for what? For 5-alpha metabolism, meaning this woman is going to be more androgenic, or maybe have more high androgen symptoms, like facial hair, thinning scalp hair, acne, than she would otherwise have, because she's got this 5-alpha preference. So that's something that providers want to evaluate. How much DHEA am I making? How much testosterone am I making? And then is there a preference for 5-alpha metabolism? If you look back at page 2, you can see a list of a few other androgens, and in other videos related to androgen metabolism that go into more detail, we can talk about those in more detail. Moving on, we see in the next page, you can see the creatinine values from all 4 samples. That is something that is going to fluctuate with hydration. So generally, when these results get below range, it means the sample is very hydrated. And I'll show you the significance of that here in a minute. And then you've got all of these individual results. You can see the cortisol metabolites down here. So those 3 added up make metabolized cortisol. So that's a calculation. And then on the next page, you can see all of this graphically represented. So you can also see melatonin on this page. So there's melatonin there on the top. All the information here was also on page 1. So the total of the DHEA metabolites, the total of the cortisol metabolites, and then down below, you can see the free cortisol pattern. So looking at the top, again, total DHEA production, total cortisol production here. And then with the cortisol production, what we can look at is cortisol comes in two forms, the active cortisol and the inactive cortisone. So it hops back and forth in different compartments of the body. And the question we're asking here is which one's predominant, the active cortisol or the inactive cortisone? And for this particular patient, there are more of the cortisol metabolites. And below, we can see the free cortisol pattern. So the first sample represents cortisol throughout the night. Remember, a waking urine sample represents the entirety of the night. The cortisol is building up in the urine. You wake up and void the bladder, collect that sample, and that's what we're looking at there. The next sample should be taken 2 hours later, and you generally see a big surge of cortisol in that sample, not in this particular example, but that's what we're looking for there. Is that's the time when cortisol is made in the highest production is in the early morning, and that's what we're trying to evaluate there over that 2 hour period, and then again in the afternoon and again at bedtime. That's active cortisol. Then we can also see inactive cortisone. What we generally describe the cortisone is it's sort of a shadow of the free cortisol pattern. So some of the cortisol, as it enters the kidney right before becoming available in the urine, gets deactivated to cortisone there in the kidney. So this represents a fraction of the cortisol. So we're really looking at that to just confirm what the overall up and down pattern is. In this particular case, you can see it really confirms just that same overall diurnal pattern. And then each of those two hormones, cortisol and cortisone, are added up, and you can see that total here, the reference range again being between the stars. So in this particular patient, they have low levels of free cortisol. We also saw before that they have relatively elevated levels of cortisol metabolites. And in that case, you're getting an idea of what's going on with cortisol metabolism. When free cortisol is low and metabolized cortisol is relatively high, there's a lot of cortisol metabolism or a lot of cortisol clearance, which is common in obesity, but also seen if someone's got excess thyroid. So that's something that your provider may want to evaluate. At the bottom of this page, you can see values for the overnight sample if in fact, the patient woke up at, say, 1 a.m. and collected a sample, and then woke up and got out of bed at 6 a.m. and collected a second sample. These waking samples, the waking result, is an aggregate of the two. So that value represents the entirety of the night. But if you want to know the individual values that make that up, you can see those here. So in this particular case, you can see that the value was 6 in the middle of the night, and then at waking was at 18, which was then combined to create that overall A value of 12, which is seen up here. So that shows the individual values if, in fact, the patient didn't sleep through the night. If the patient sleeps through the night, then that waking sample is just one single sample, and it represents the entirety of the night. Lastly, we've recently added some new tests to our Dutch Complete profile. So melatonin, we've had for some time. 8-hydroxydeoxyguanosine was more recently added, but within the real recent past, we've added these organic acids. So on this page, you can see there's no graphical representation of these results with the exception of melatonin, but we're simply looking at whether they're in range or not. So we've got a marker for B12, so methylmalonate or methylmalonic acid gets elevated when a patient is deficient in B12. You can see that value here, and its ranges here. This sample report was created before the finalizing of the reference ranges. So these reference ranges here are not actually the reference ranges. This is just an example. You can see next xanthuronate or xanthuronic acid. That's a marker for vitamin B6 deficiency. So if a patient is deficient in B6, you'll tend to see that value being elevated as it is in this case. Pyroglutamate is a glutathione deficiency marker. So if it's elevated, patients may be deficient in glutathione. The particular way that pyroglutamate is produced, if the result is below range, as it is in this example, you may also have a glutathione deficiency. Lastly, you can see the neurotransmitter metabolites, so the dopamine metabolite, HVA, the norepinephrine and epinephrine. Epinephrine is another name for adrenaline. The metabolite of those is VMA, and then the serotonin metabolite is 5-hydroxyindolyl acetate. So we can see the organic acids there on that page, and that gives you an overview of all of the hormones and metabolites that we're looking at with the Dutch Complete. I hope that's been helpful in understanding your results, and we look forward to continuing to work with you.